Ameloblastoma or adamantenoma. Ameloblastoma or adamantenoma is locally malignant tumor, and we all know that locally malignant tumor is spread only direct spread without any lymphatic or blood spread. It is much more common in the lower jaw, more common in female. This is a female. Usually appear and rise and start at the age of 25 to 45 years. It is the commonest mandibular tumor. This tumor arises from its name. It is called ameloblastoma because it arises from the ameloblast. And in the previous videos, we know that ameloblasts are cells present during development of teeth in the dental follicle. Some of these cells persist after birth and remain until young age, where it undergo locally malignant changes and becomes ameloblastoma. Ameloblastoma or adamantenoma usually start in the angle of the mandible and spread in the body of the mandible and in the ramus of the mandible. Cut section of this tumor is either white like this or pinkish according to the amount of fibrous tissue. It is pinkish or white. It is well encapsulated tumor. Fibrous tissue trabeculae divides the tumor into equal small compartments. Therefore, these equal small compartments in X-ray appear like honeycomb appearance. It is consists of solid area and cystic areas. The cystic area containing mucoid brownish substance, and the solid area containing fibrous tissue. And microscopically, these solid areas containing epithelial elements. This solid area containing fibrous tissue, like that, mass of fibrous tissue, and containing epithelial elements arranged in cords, acini, cell nests, or masses of basal cells. Cystic areas microscopically lined by squamous or columnar epithelium and containing mucoid material. What is the complication of ameloblastoma? The complications of ameloblastoma when the swelling enlarge. When the swelling enlarge, it produces direct spread, mainly to a surrounding mandibular tissue. And in advanced cases, it may spread to the soft tissue around the mandible. And spread here is only direct. If blood or lymphatic spread occur, this is not adamantenoma, not ameloblastoma. It is malignant changes. Ameloblastoma from the epithelial element may turn to carcinoma, or from the fibrous tissue element may turn to sarcoma, leading to lymphatic or blood spread. It is common after surgery for removal of adamantenoma is recurrence. After surgery, recurrence due to cellular implantation in the surrounding tissues. When the swelling enlarges, it will push the surrounding teeth, leading to displacement of teeth, loosening of teeth, and the falling of the teeth. When the swelling markedly enlarges, ulceration, infection, and pathological fracture of the jaw may occur. What is the clinical picture of adamantenoma? The clinical picture of adamantenoma is swelling. Swelling in the angle of the mandible, and this swelling painless, not tender, well defined, slowly growing, lobulated, and the swelling starts in the angle, and as it enlarges horizontally in the body and vertically in the ramus. Early, as any bony swelling, the swelling is hard, but later on, marked enlargement of the swelling leading to thinning of the cortical bone, and the swelling has the famous consistency of eggshell crackling sensation. This tumor produces expansion of the bone more on the outer surface. If you look from inside the mouth, the swelling is very small. But if you look from outside the mandible, the swelling is markedly enlarged. Therefore, the bone expansion is more on the outer surface. The related teeth are mal-directed and loose, no lymph node enlargement, and lymph node enlargement may occur only if ulceration and secondary infection of the tumor occur. This will lead to non-specific lymphadenitis and the enlargement of lymph nodes, or sure if there is carcinomatous changes. Investigation plain X-ray. Plain X-ray will show the bone expansion, thinning of cortical bone, and the swelling is divided into nearly equal compartments, like honeycomb appearance. CT scan is important to show the local extension of the tumor. Biopsy is diagnostic. What is the treatment of ameloblastoma and differential diagnosis of ameloblastoma? Differential diagnosis of ameloblastoma is osteoclastoma of the mandible. What's the difference between osteoclastoma and adamantenoma? Osteoclastoma usually start in the symphysis mentis and spread in the body of the mandible only. Usually doesn't extend to the angle or the ramus. In contrast, adamantenoma start in the angle and spread vertically in the ramus and horizontally in the body of the mandible. Osteoclastoma is equal in male and female, but we said before that adamantenoma is much more common in female. The color of adamantenoma is pinkish or white according to the amount of fibrous tissue and the vascularity, while osteoclastoma is brownish in color. The surface of adamantenoma is finely lobulated, while osteoclastoma there is coarse lobulation. Expansion in osteoclastoma on the outer surface mainly, less expansion from the oral cavity in the inner surface. In contrast to this is osteoclastoma. Expansion of the mandible occur equally on both outer and inner surface. X-ray show honeycomb appearance in Adamantenoma, while the lobulation is large in osteoclastoma gives the famous X-ray appearance of soap bubble appearance. Treatment sure is only surgical because Adamantenoma is radio resistant. Surgical is some sort of mandibulectomy followed by reconstruction of the mandible. If a small tumor, we excise a segment of the mandible between the two famous foramina of the mandible. The mandibular foramen, we excise from the mandibular foramen to the mental foramen, because between the mandibular foramen and the mental foramen there is a canal called mandibular canal or inferior alveolar canal, and tumor here usually spread in this canal. Therefore, the aim of mandibulectomy at least removal of a part of mandible from the mandibular foramen to the mental foramen to remove this canal, which is called mandibular canal or inferior alveolar canal, which is sure containing malignant cells. If the tumor is large, we should remove half of the mandible. Hemimandibulectomy. After mandibulectomy, we need mandibular reconstruction. Why mandibular reconstruction is essential? For occlusion of teeth and for application of denture and cosmetically. What is the methods of mandibular reconstruction? The methods of mandibular reconstruction, first of all, and the most popular nowadays, is graft from the patient. And you all know any graft from the patient is called autogenous graft. We take autogenous graft from the patient bone. Usually the fibula is the site of the graft. We take parts of the fibula and we put these parts to close the defect in the mandible. This is anterior view and this is inferior view. These are the fibular graft. This is called non-vascularized graft. The most famous donor is the fibula or the fifth rib. There is another autogenous graft, but it's very difficult, which is called vascularized graft. This non-vascularized, we take the bone only. While in vascularized graft, we take the bone and its blood supply. To anastomose this blood supply with local blood vessels, like facial vessels. But this technique is very difficult because we need microsurgical technique. After we put fragments and parts of fibula or the rib here, how to fix this graft? We fix this graft by this. What is this? This is called mandibular plate and screws. We fix the remaining parts of the bone and the multiple fragments of the non-vascularized graft with mandibular plate and screws. Or mandibular prosthesis is available. In hemimandibulectomy, there is mandibular prosthesis for half of the mandible. And in total mandibulectomy, there is mandibular prosthesis to replace the whole mandible and to apply the denture and to give the full cosmetic appearance as usual. This is Blastoma or Adamantenoma. Thank you for good listening and good luck.